This talk was given at the Western Medical Research Conference in Carmel, California on January 20th, 2023. I'm Dr. Raphael Stricker, and the title of the talk is Does Sex Matter in Lyme Disease? The Need for Sex Disaggregated Data in Persistent Illness. Authors are Lorraine Johnson, Myra Shapiro, Sylvia Janicki, Jennifer Mankoff, and Raphael Stricker. I have no conflicts of interest to disclose. As background for the talk, in the USA, Lyme disease is caused by the spirochete Borrelia burgdorferi, which is transmitted by black-legged ticks, Ixodes scapularis in the east and Ixodes pacificus in the west. The Centers for Disease Control and Prevention estimates that 476,000 new cases of Lyme disease occur annually in the USA. If diagnosed and treated promptly, most patients recover without complications. However, even patients who are diagnosed early can remain ill after antibiotic treatment. In a recent study from Johns Hopkins University, 43% of Lyme disease patients reported persisting symptoms 6 months or more after early treatment. Only 57% of patients were classified as having recovered from their illness. And many patients are not diagnosed and treated early for Lyme disease, which further increases their risk of remaining ill after initial antibiotic treatment. Now, why is Lyme disease so difficult to address? The classic features of Lyme disease include a tick bite, and then an erythema migrans or bullseye rash, and then frank arthritis with joint swelling, and also positive antibody testing. However, only 50 to 60% of Lyme patients recall a tick bite. Only 35 to 60% of Lyme patients ever see a rash, and the rash may have a variable appearance and location, as you'll see in a minute. Only 20 to 30% of Lyme patients get joint swelling, and this may be masked by anti-inflammatory medications. And the FDA-cleared tests for Lyme disease miss more than half of Lyme disease cases, so they are very insensitive. Now, the EM, erythema migrans, or bullseye rash may have different shapes and sizes and locations, as shown on this slide. In fact, only about 10% of erythema migrans Lyme rashes are in the shape of a bullseye, and the rash may not be recognized as due to Lyme disease. Now, the other problem with Lyme disease is that it has become a much more complicated disease. We know that ticks are sewers of infection. Basically, anything that they pick up, they can transmit to humans. And there are a number of co-infections that go with the Lyme bacteria, as shown on this slide. These tick-borne co-infections make it much more difficult to treat Lyme disease and make the disease a very complex entity that can be very challenging for the clinician. So the question is, what other factors are involved in the complexity of this disease? Well, although there is growing recognition that biological sex is an important clinical variable when analyzing research findings, very few Lyme disease studies were designed to consider sex-based differences or gender bias as an important component in tick-borne disease research. Our goal was to examine the association between biological sex and outcome measures in patients with persistent Lyme disease symptoms. The study was based on data obtained through the My Lyme Data Registry, a project of LymeDisease.org. This patient registry was established in 2015. To date, the registry has enrolled over 17,000 patients with Lyme disease, and it has had an impact on both research and clinical studies of Lyme with 6 peer-reviewed studies, citations in NIH reports and professional and government conferences, and also a recognition by various universities and the National Science Foundation, and also used in pharmaceutical clinical studies. So we analyzed clinical data for more than 2,000 Lyme disease patients in the My Lyme Data Registry to assess sex-based differences in individuals who reported persistent symptoms for 6 or more months after receiving antibiotic treatment. We also reviewed previous Lyme disease studies for distribution of patients by biological sex, according to disease stage, data source, and disease definition used to screen patients for enrollment. And statistical analysis of clinical results was performed using Fisher's exact test for non-parametric variables. Now, we used 3 basic categories for the definition of Lyme disease. Acute Lyme disease involved patients who were clinically diagnosed within 3 to 6 months after the onset of disease. In contrast to that, there are 2 definitions for persistent or chronic Lyme disease, one based on randomized controlled trials and post-treatment Lyme disease, which involves patients who are clinically diagnosed based on stringent inclusion criteria with persisting illness greater than 6 months. These stringent criteria exclude about 89 to 99% of possible research subjects with Lyme disease. Now, in contrast to that, there is the persistent Lyme disease or chronic Lyme disease definition, which involves patients who are clinically diagnosed based on less restrictive inclusion criteria with persisting illness for greater than 6 months. So these are the inclusion criteria. We started with 4,719 respondents. We excluded duplicate responses, non-US residents, and patients who had incomplete clinical information. And we came up with 3,892 patients. Of these, 2,170 were recognized as having persistent Lyme disease or chronic Lyme disease. And that breaks down as 1,839 women and 331 men. The demographic characteristics of these respondents are shown on this slide. The mean age was 49 years and did not differ between men and women. In terms of education and family income, we had higher levels for both of those values. And in terms of geography, about 1/3 of patients came from the East Coast and the rest were distributed around the country. All patients in this survey were diagnosed by a clinician, and all patients were diagnosed as having persistent Lyme disease or chronic Lyme disease. Only 45% of patients recalled an EM rash, a Lyme rash, and 82% of patients had supportive laboratory tests, and that did not differ between men and women. However, 80% of patients had one or more co-infection, and women had significantly more co-infections compared to men. So results, women with Lyme disease reported significantly worse symptoms of fatigue, myalgias, arthralgias, insomnia, headache, and gastrointestinal upset compared to men. Women also had significantly longer diagnostic delays, more misdiagnoses, and worse quality of life compared to men. And women had significantly more tick-borne co-infections compared to men. More than half of respondents on antibiotics, 57%, reported improvement over time since initiation of treatment. Approximately 8% of respondents reported side effects associated with their current antibiotic, and there was no significant difference between the sexes in effectiveness or side effects associated with antibiotic treatment. So to show you this graphically, women have a greater symptom severity compared to men in these 6 categories: fatigue, muscle aches, joint pain, sleep impairment, gastrointestinal symptoms, and headache. Interestingly, men had more severe twitching, cognitive impairment, and heart-related conditions compared to women, but the difference was not statistically significant. In terms of diagnostic delays for patients diagnosed within 1 month, there was no difference between men and women, but only 8% of the subjects fell into that category. In contrast, in patients diagnosed at a late stage or diagnosed greater than 3 years after onset of disease, women were overrepresented in these groups compared to men. And also in patients who had seen 10 or more clinicians before diagnosis, there were significantly more women who fell into that category compared to men. In terms of misdiagnosis, the most common misdiagnoses were chronic fatigue syndrome and fibromyalgia syndrome, as well as psychiatric disorders, usually depression. In all of these categories, women outnumbered men by a significant margin, and more than 3/4 of patients had a previous misdiagnosis, again, with women outnumbering men significantly in this category. And then in terms of quality of life, interestingly, for self-rated health status, almost 3/4 of patients rated their health status fair or poor, and there was no difference between men and women in terms of self-rating of their health status. However, when we looked at specific factors such as a disability, special equipment needs, and 8 or more bed days per 6 months, women outnumbered men by a significant margin in these categories of quality of life. So in our review of clinical research studies and data sources, we identified a smaller percentage of women among patients with acute Lyme disease, 37 to 42%, and a larger percentage of women among patients with persisting illness, 44 to 88%. Samples and data sources that were more reflective of symptomatic patients seen in clinical practice had a higher percentage of women, 66 to 88%, than either randomized controlled trials or narrowly defined studies of post-treatment Lyme disease, 44 to 72%. And to show you this graphically, at the top, in acute Lyme disease, women were somewhat underrepresented, 42%. However, in the randomized controlled trial and post-treatment Lyme disease groups, women were overrepresented, 58%. And in the persistent Lyme disease or chronic Lyme disease groups, women were significantly overrepresented, with 77% of patients being women in these categories. So in conclusion, women with Lyme disease reported significantly worse symptoms of fatigue, myalgias, arthralgias, insomnia, headache, and gastrointestinal upset compared to men. Women also had significantly more co-infections, longer diagnostic delays, more misdiagnoses, and worse quality of life compared to men. No differences between men and women were reported in antibiotic treatment response or side effects of treatment. And while men outnumbered women in studies of acute Lyme disease, women outnumbered men in studies of persistent or chronic Lyme disease. And our results indicate that biological sex should be integrated into future Lyme disease research as a distinct variable. Inclusion of sex-based disaggregated data should increase our understanding of differences between men and women in the evolution of persistent Lyme disease symptoms. And I would like to acknowledge my coworkers at LymeDisease.org and also Union Square Medical Associates, and also thank the Bill and Marianne Cook Foundation, the Bruce Lindorf Memorial Foundation, and the Peterson Family Foundation of Orem, Utah, for their generous support. And for more information about tick-borne diseases, please visit the LymeDisease.org website at www.lymedisease.org. Thank you very much for your attention.